Good afternoon, everybody. Today we are going to discuss about the inherited disorders of globin synthesis. I am Dr. Guvera Vasireddy, your assistant professor in pathology. Different hemoglobins are synthesized in the embryo, fetus, and adults, each adapted to their particular oxygen requirement. They all have a tetrameric structure made up of two different pairs, one alpha-like and one beta-like of globin chains, each attached to one heme molecule, the moiety responsible for reversible binding and transfer of oxygen. This is the diagrammatic representation of the heme molecule. You can see the various globin chains colored in differently and the central heme molecule which binds to the oxygen reversibly. So we will go through the various globin chains that are part of hemoglobin from the embryonic stage to the adult stage. Like alpha globin, it contains 141 amino acids and it is coded for on chromosome 16, and it is found in normal adult hemoglobin, both A1 and A2. Next one is beta globin. It contains 146 amino acids coded for on chromosome level, found in HbA1. And the next one is delta globin, found in hemoglobin A2, small amounts in all adults. Next, gamma globin, found in fetal hemoglobin. Zeta globin, found in embryonic hemoglobin. So here you can see beta globin complex on chromosome 11, chromosome 16 hosting the alpha globin complex, and embryonic that is HB Gover1, Gover2, Portland, fetal HbF2 and HbA and A2, which are made up of alpha 2 and beta 2 and HbA2, alpha 2 and delta 2. The main globin gene clusters are located on chromosome 11 and 16, and at each stage of development different genes in these clusters are activated or repressed. The different globin chains directed by individual genes are synthesized independently and combined in random fashion as indicated by the arrows. You can see the diagram like how different globin genes combine to give the hemoglobin molecules at different stages of the embryonic, fetal and adult development. You can see except in the embryonic period, in all other phases, alpha globin chain is an essential part of the hemoglobin molecule. So that's why mutations in the alpha globin gene are not viable with life, and they result in hydrops fetalis, and they don't are not as common as the mutations in beta globin chain. Here you can see the diagrammatic representation of the prevalence of each kind of hemoglobin according to the age of the embryo or fetus or the adult. Like, you can also see that hematopoiesis takes place in yolk sac in embryonic period, and then liver and spleen in fetal period, and then shifts to bone marrow once the child is born. So whenever you suspect any hemoglobin error, first things are done using blood sample. These tests are done on the blood sample. Complete blood count, peripheral film examination, hemoglobin analysis by electrophoresis or HPLC. So HPLC is the most common method done nowadays because electrophoresis is more cumbersome and more technically challenging. There are two types of hemoglobin electrophoresis. One is alkaline extraction, the other one is acid extraction. Next one is high performance liquid chromatography or HPLC, which is done more commonly nowadays, and this is done using a weak cation exchange column, the ionic strength of the eluting solution is gradually increased and causes the various hemoglobin molecules to have a particular retention time. Amino acid substitution will alter the retention time relative to hemoglobin A. There is some analogy between retention time and pattern on alkaline electrophoresis. So, HPLC is somewhat similar to extraction on alkaline electrophoresis. And once you diagnose abnormal hemoglobins on the HPLC or hemoglobin electrophoresis, next thing is done by DNA analysis. Several molecular techniques are available, which include from DNA from white blood cell, amniocytes or chorionic tissue may be utilized for diagnosis of various alpha and beta globin chain abnormality. This is because most of the mature RBC lack any nucleus and they cannot be used for DNA analysis. Typically, deletion is causing alpha thalassemia syndromes and some rare beta thalassemias are diagnosed during southern blot hybridization of particular restriction enzyme digest to label complementary gene probes. PCR techniques using allele specific probes after globin gene amplification, allele specific primers or deletion dependent amplification with flanking primers are also used. In definition of known globin chain mutations, deletions including those for HBS, E, D and O and several beta thalassemias. For unknown mutations, several PCR based methods including denaturating gradient gel electrophoresis and single strand conformation, polymorphism analysis as well as sequencing of the amplified gene DNA may be used. So, once you know that a parent or somebody is one of the parents is suffering from either thalassemia minor, thalassemia major or any other hemoglobinopathy, once the patient patient carrying the trait becomes pregnant, their blood is analyzed for presence of fetal DNA with abnormalities that are associated with these hemoglobinopathies. Usually this test is called as prenatal non-invasive testing, usually performed before 16th week of gestation to be more reliable. It can be done earlier also, but if it is done around 16th week of gestation, it will be more reliable. So, first coming to the thalassemias and related disorders. These are thalassemias are the common name given to the thalassemias and related disorders. These are the syndromes that are the result of qualitative disorders of hemoglobin synthesis resulting from defective globin genes. According to the chain whose synthesis is impaired, the thalassemias are called alpha thalassemia, beta thalassemia, gamma, delta or delta B or other names. Like usually, these subgroups have in common an imbalanced globin synthesis. Consequently, the globin produced in excess is responsible for the ineffective erythropoiesis, that is intramedullary destruction of erythroid precursors and hemolysis, peripheral destruction of red cells. Usually alpha beta thalassemias are more common, while gamma, delta and other thalassemias are not compatible with life. That's why we don't see many thalassemias related to the impaired synthesis of those globin chains. The application of recombinant DNA technology has permitted the understanding of the basic aspects of gene structure and function and the characterization of the molecular basis for deficient globin synthesis. The thalassemias result from the effect of a large number of different molecular defects. These may interact leading to a variety of clinical and hematologic phenotypes. In 1925, Cooley and Lee first described a form of severe anemia that occurred early in life and was associated with splenomegaly and bone changes. In 1932, George H. Whipple and William L. Bradford published a comprehensive account of the pathologic findings in this disease. Whipple coined the phrase thalassaemic anemia and condensed it to thalassemia from the word thalassa means sea because early patients were all of Mediterranean background. The true genetic character of the disorder became fully appreciated only after 1940. The disease described by Cooley and Lee is the homozygous state of an autosomal gene. The heterozygous state is associated with much milder hematologic changes. The severe homozygous condition became known as thalassemia major. The heterozygous states were designated according to the severity as thalassemia minor or minima or even intermedia. The term thalassemia intermedia was used to describe disorders that were milder than the major form but more severe than the traits. Prevalence, geographic distribution and role of malaria. That malaria had an influence in maintaining the high prevalence of hemoglobinopathy in the world was first suggested by in 1948 by Haldane. The small red cells of the carriers of thalassemia could be more resistant to malarial parasite. Earlier, Neal and Valentine had calculated that in the absence of some kind of selective pressure, the mutation rate of thalassemia had to be in the order of 1 in 2500. Selective pressure of malaria has amplified the beta thalassemia genes to high frequency in those areas where the malaria is endemic. So, here you can see the distribution of beta thalassemia across the world. You can see that India and Southeast Asia is placed in high prevalence areas. So, these are the clinical syndromes which can occur with deletion or mutation of the globin chain. That is, beta thalassemia, homozygous beta thalassemia can result from entire deletion of the beta globin chain or beta thalassemia intermedia with the variable deletion of number of the chains because one pair is there on the chromosome 11 and one of them get deleted and the other can be present. And beta thalassemia minor, it can be one of the chains can be impaired and or deleted. So, the beta thalassemias are caused by mutations that diminish the synthesis of beta globin chains. The causative mutations fall into two categories. One is beta 0 mutation associated with absent beta globin synthesis and beta plus mutation characterized by reduced but detectable globin synthesis. Types of mutation in beta thalassemia. First one is splicing mutation. These are the most common cause of beta plus thalassemia. Most of these mutations lie within introns while few are located within exon. And the next one is promoter region mutation. These mutations reduce transcription and some normal beta globin is synthesized. Thus, these mutations are associated with beta plus thalassemia. And chain terminator mutations. These are the most common cause of beta 0 thalassemia. So, this is common types create a new stop codon within an exon. Second type are the frame shift mutation. Both block translation and prevent the synthesis of any functional beta globin chain. So, here you can see the recessive forms of thalassemia, dominantly inherited beta thalassemia and hinge body hemolytic disease. So, in alpha 2 and globin beta 1 beta plus thalassemias, the main pathogenesis lies in excessive alpha chain synthesis than the deficiency in beta thalassemia, beta globin chain. And dominantly inherited beta thalassemia, that is excessive alpha chains together with less beta globin chain synthesis. And hinge body hemolytic anemia is alpha 2 and beta 2 plus unstable alpha 2 and beta 2. One of the globin chains is abnormal, so it results in abnormal beta globin chain synthesis along with the normal beta chain. So, those hemoglobin molecules which include abnormal beta globin chain and which combines with normal alpha will lead to peripheral hemolysis. So, this syndrome is much milder than the dominantly inherited beta thalassemia. See, you can see the various modes of genetic mutations in thalassemias. Impaired beta globin synthesis result in anemia by two mechanisms. One is that deficit in HbA synthesis produces underhemoglobinized hypochromic microcytic red cells with subnormal oxygen transport capacity. Even more important is the diminished survival of the red cells and their precursors, which result from the imbalance in alpha and beta globin chain. At the start of this chapter, we have discussed about ineffective erythropoiesis. So, any excess alpha chains will get precipitated in the cytoplasm of these immature RBC, and these cells are liable for hemolysis in the reticuloendothelial system in the bone marrow itself. So, this is called as the ineffective erythropoiesis. Unpaired alpha chains precipitate with, so this is the mechanism described again. These inclusions cause membrane damage and is the cause of most red cell pathology. Many red cell precursors succumb to membrane damage and undergo apoptosis. 70 to 85% of red cell precursors suffer this fate, which leads to ineffective erythropoiesis. Those red cells that are released from the marrow also bear inclusions and membrane damage and are prone to splenic sequestration and extravascular hemolysis. So, severe uncompensated anemia leads to massive erythroid hyperplasia in the marrow and excessive extramedullary hematopoiesis. The expanding mass of red cell precursors erodes the bony cortex, impairs bone growth, and produces skeletal abnormalities. Extramedullary hematopoiesis involves the liver, spleen, and lymph nodes, and extreme cases produces extraosseous masses in thorax, abdomen, and pelvis, and sometimes even in lymph nodes in far off places like cervical lymph nodes and other places also. The metabolically active erythroid progenitors steal nutrient from other tissues that are already oxygen starved, causing severe cachexia in untreated patients. So, most of the patients born with thalassemia major, if they don't undergo transfusion as soon as after the birth, they die of all these changes: ineffective erythropoiesis, anemia, and nutrient deficiency. And secondary hemochromatosis. Another serious complication of ineffective erythropoiesis is the excessive absorption of dietary iron. As you know, dietary iron absorption is controlled by hepcidin. So, in cases of anemia or hypoxia, this hepcidin secretion is undergoes inhibition, and it results in lack of control on intestinal iron absorption. This leads to increased iron absorption from the intestine, and again ineffective erythropoiesis suppress the circadian level of hepcidin, and which is a critical negative regulator of iron absorption even into the tissues also. Low levels of hepcidin and iron load of repeated blood transfusion inevitably lead to severe iron overload unless preventive steps are taken. Secondary injury to parenchymal organs, particularly the iron-laden liver, often follows and sometimes induces secondary hemochromatosis. So, even without transfusion, in some patients with thalassemia trait, which is serious enough to cause ineffective erythropoiesis and anemia, progressively there is increased iron absorption and increased iron storage in reticuloendothelial system as well as in liver, which leads to secondary hemochromatosis, and even pancreas and heart also get affected, which is called as bronchodiabetes. So, here is the diagrammatic representation of the various pathogenic changes that take place in beta thalassemia major. You can see the hematopoiesis, expansion of the hematopoiesis in long bones, which is usually limited in adults, but in thalassemia patients, because of the constant anemia, it gets expanded, and even extramedullary hematopoiesis takes place. So, this is the diagrammatic representation with flow chart. Remember this chart, you will be able to write the essay properly. So, this is the various pathways of pathogenesis in beta thalassemia, because the central to the pathogenesis is the alpha globin excess, even in the presence of normal amounts of beta globin chains. So here is the same. And clinical syndromes in beta thalassemia. First one is beta thalassemia major. This is the homozygous state. Severe, requires blood transfusion frequently, and incompatible with life unless diagnosed early, and blood transfusions and other medications are started early in life. Beta thalassemia intermediate, severe but does not require regular blood transfusions. And beta thalassemia minor, asymptomatic with mild or absent anemia, red cell abnormalities are seen. But even in those cases of intermediate and thalassemia minor, where there is no requirement of transfusion, other associated results of or sequelae of hemolytic anemia are seen, like gallstones, trophic ulcers on the screen, and other things will be seen in these patients as well. And they are also prone for various crises that occur in beta thalassemia major or even other hemolytic anemias. So here is the peripheral smear morphology. This is very important for you. You should remember marked variation in size, which is called as anisocytosis, and shape, poikilocytosis, microcytosis, and hypochromia, and target cells, so called because the hemoglobin collects in the center of the cell. Basophilic stippling and fragmented red cells are also common. Inclusions of aggregates of alpha chains are efficiently removed by the spleen and are not easily seen in the peripheral smear. The reticulocyte count is elevated but is lower than expected for the severity of anemia because of the ineffective erythropoiesis. Variable numbers of poorly hemoglobinized nucleated red cell precursors are seen in the peripheral blood as a result of stress erythropoiesis and abnormal release from the sites of extramedullary hematopoiesis. Here you can see the microphotographs of peripheral smear of those patients with beta thalassemia. You can see the target cells with round cells with central dot like thing, and variability of the size, which is called as poikilocytosis, and abnormal RBC with the nucleus and fragmented RBC. This is the thalassemia trait blood film. Here you can see the poikilocytosis is less prevalent than that of a thalassemia major patient. Here you can see the target cells. But presence of target cells is not always an indication of presence of thalassemia. It can occur in other conditions also. And basophilic stippling, you can see the blue dots around in the RBC, and it is because of the abnormal iron or ferritin storage in these cells. Thalassemia trait and major both show basophilic stippling, hemolytic anemias, myelodysplastic syndrome, megaloblastic anemia, pyrimidine and 5 nucleotide deficiency, and heavy metal poisoning like lead, zinc, arsenic, and silver mercury. These are the conditions in which you will see basophilic stippling, but it will be different and less than that of hemoglobin beta thalassemia. In the bones of the face and skull, the burgeoning marrow erodes existing cortical bone and induces the new bone formation, giving rise to crew-cut appearance on X-ray. I will show you the photograph in the next slide. Both phagocyte hyperplasia and extramedullary hematopoiesis contribute to enlargement of the spleen, which can weigh as much as 1500 grams. Usually it weighs around 150 grams. The liver and the lymph nodes can also be enlarged by extramedullary hematopoiesis. Hemosiderosis and secondary hemochromatosis occur in almost all the patients. The deposited iron often damages organ, most notably heart, liver, and the pancreas. So here you can see the bone marrow morphology in thalassemia patients. Usually only 50% of the marrow is occupied by cellular component, and rest of it will be fat and other things. But here you can see more than 75% of the marrow being occupied by the cellular components. And here you can see the mm, immature RBC with nuclear RBC. This is the film which is the X-ray of the skull, which shows the crew cut appearance or military style of hair cutting, like which when you make the hair too short, they will rise on their ends. Here are the patients who are not optimally treated for beta thalassemia major. Here you can see because of the hematopoietic expansion of the bone marrow in the facial bones leading to deformity of the face. Here you can see the hepatosplenomegaly giving rise to pot belly like. The clinical course of beta thalassemia major is brief unless blood transfusions are given. Untreated children suffer from growth retardation and die at an early age from effects of anemia. In those who survive long enough, the cheekbones and other bony prominences are enlarged and distorted. Hepatosplenomegaly due to extramedullary hematopoiesis is usually present. Although blood transfusion improves the anemia and suppresses complications related to excessive erythropoiesis, they lead to complications of their own. Cardiac disease resulting from progressive iron overload and secondary hematochromosis is an important cause of death in these patients, particularly in heavily transfused patients who must be treated with iron chelators to prevent or reduce this complication. With transfusion and iron chelation, survival into third decade is possible, but the overall outlook remains guarded. Bone marrow transplantation is the only therapy offering a cure and is being used increasingly. Prenatal diagnosis is possible by molecular analysis of DNA. So that's what I mentioned initially, prenatal non-invasive diagnosis is the option for diagnosing these conditions even before the birth of the child. And thalassemia minor is much more common because these children survive into adulthood. Beta thalassemia major and understandably affects the same ethnic groups. Most patients are heterozygous carriers of beta plus or beta 0 allele. These patients are usually asymptomatic. Anemia, if present, is mild. The peripheral blood smear shows hypochromia, microcytosis, basophilic stippling, and target cells. Mild erythroid hyperplasia is seen in the bone marrow. Hemoglobin electrophoresis usually reveals an increase in HbA2, that is Hb made up of alpha 2 and delta 2 chains, to 4% to 8% of the total hemoglobin. Normal is less than 2.5%, which is a reflection of the elevated ratio of delta chain to the beta chain synthesis. HbF levels are generally normal or occasionally slightly increased. So this is the difference between the electrophoresis in hemoglobin sickle cell anemia and beta thalassemia. In sickle cell anemia, you can directly see the HbS, but in treated patients with sickle cell anemia, you can observe a rise in hemoglobin F levels. But in thalassemia, most of the times it is HbA2, which gives an indication of the presence of thalassemia. Differentiation from the hypochromic microcytic anemia of iron deficiency and genetic counseling. So the most important thing about diagnosing beta thalassemia trait is to give genetic counsel so that we can prevent the birth of a homozygous patient with homozygous form of beta thalassemia, which carries a lot of morbidity and mortality. Iron deficiency can usually be excluded through measurement of iron, serum iron, total iron bearing capacity, and serum ferritin. The increase in HbA2 is diagnostically useful, particularly in individuals of childbearing age who are at risk for both beta thalassemia trait and iron deficiency. Usually in countries where the beta thalassemia is prevalent, like even in our countries, those patients whose hemoglobin is less than 8 are usually screened for the presence of thalassemia, but usually it is not being done nowadays more commonly. So here you can see the HPLC histogram showing a spike in HbA along with HbA2. So next of the syndromes are alpha thalassemias. These are much more rarer because alpha chain is sensitized by two pairs of alleles. Like instead of beta globin chain is synthesized by only one pair of genes. Alpha thalassemias are caused by inherited deletions that result in reduced or absent synthesis of globin chains. The severity of alpha thalassemia depends on how many alpha globin genes are affected. Anemia stems from both lack of adequate hemoglobin and the effects of excess unpaired alpha chains, beta, gamma, and delta, which vary in type at different ages. Here you can see the prevalence of this alpha thalassemia. So you can see a black area in the Southeast Asia and Indochina where the alpha thalassemia is much more prevalent. So next coming to the this is as you know earlier we have discussed alpha globin chain is represented by two pairs of genes on chromosome 16, one pair each on one autosomal autosome, and if only one gene is deleted, then there is no abnormality, usually asymptomatic, no red cell abnormality. Also a thalassemia trait, this trait is more common in Asians, which results from deletion of one pair entirely from one of the 16th chromosomes. And next one is HBH disease, which is only one alpha gene is present leading to the excess of beta thalassemia. This HBH is found by apparently by 4 chains of beta globin. Hydrops fetalis, no alpha chain is present, so it is lethal and the child will die in utero itself. In newborns with alpha thalassemia, excess unpaired gamma globin chains and gamma tetramers known as hemoglobin parts. In older children and adults, excess beta globin chains form beta 4 tetramers known as HBH. Free beta and gamma chains are more soluble than free alpha chains and form fairly stable hemotetramers. Hemolysis and ineffective erythropoiesis are less severe than in beta thalassemia. A variety of molecular regions gave rise to alpha thalassemia, but gene deletion is the most common cause of reduced alpha chain synthesis. Here you can see the severity of the disease according to the presence or absence of alleles on the genes. Silent carrier, no disease, patient remains asymptomatic. Alpha thalassemia trait, this is result from absence of more than 2 alpha genes. So this genotype is more common in Asian population. The children affected by individuals who are at risk clinically significant of alpha thalassemia, HBH disease or hydrops fetalis only when at least one parent has alpha haplotype. As a result, symptomatic alpha thalassemia is relatively common in Asian population and rare in Black African population. The clinical picture of alpha thalassemia trait is identical to that described for beta thalassemia minor. Next one is hemoglobin H disease caused by deletion of 3 alpha globin genes. HBH disease is most common in Asian population. With only one normal alpha globin gene, the synthesis of chains is markedly reduced and tetramers of beta globin called HBH form. HBH has an extremely high affinity for oxygen and therefore is not used for oxygen delivery, leading to tissue hypoxia disproportionate to the level of hemoglobin. HBH is prone to oxidation, which causes it to precipitate out and form intracellular inclusions and promote red cell sequestration and phagocytosis in the spleen. The result is a moderately severe anemia resembling beta thalassemia intermedia. So here you can see the blood film in a patient with HbH disease. You can see a lot of target cells and some of the cells with basophilic stifling. And hydrops fetalis. This is the most severe form of alpha thalassemia caused by deletion of all 4 globin genes. In the fetus, excess gamma globin chains form tetramers that have much high affinity for oxygen that they deliver little to tissues. Survival in early development is due to the expression of zeta chains and embryonic globin that pairs with gamma chains to form a functional zeta to gamma to Hb tetramer. Signs of fetal distress usually become evident by third trimester of pregnancy. The fetus shows severe pallor, generalized edema, and massive hepatosplenomegaly, similar to that seen in hemolytic disease of the newborn. In the past, severe tissue anoxia led to death of in utero or shortly after birth. With intrauterine transfusion, many such infants are now saved. There is a lifelong dependence on blood transfusion for survival, with the associated risk of iron overload. As you know, like bone marrow transplantation can be curative, but most of the time, bone marrow transplantation is not that much simple. It is associated with immunoincompetence and immunosuppression, and prevention is better than cure always. Here you can see a baby with hydrops fetalis with a huge liver and edematous body. The carry home message is all anemias, whether they are symptomatic or not, should be evaluated fully. Importance of early diagnosis and appropriate treatment in every case, as any delay might lead to increased mortality, skeletal defects, and significant growth retardation. Patients should be provided with adequate counseling regarding the risk of progeny. In carriers and symptomatic pregnant women, prenatal diagnosis should be advised. Thank you.